Greetings, everyone. It's a great pleasure to be a part of this wonderful initiative of series of lectures regarding the Silk Road, which goes back, of course, to ancient times. I am sorry that I can't be there in person, but I certainly am there in spirit. This is a very difficult concept, maybe for some people to understand, because the risk assessment process isn't just using various risk assessment tools. It's a whole compilation of things. And clinical and surgical experience, VTE risk assessment tools are important, as subsequent evidence. Patient values and opinions are also important. And in this lecture, we're going to focus on the multifaceted nature of risk assessment. These are my disclosures. And I'd like to start off with a concept that I call the Caprini High Five. It consists of taking a look at evidence-based guidelines, subsequent literature not reviewed by the guidelines, the RIETE database, risk assessment models, and finally clinical experience and judgment. And there's a sequence of events here depending on what the nature of the situation is. Now, let us never forget what history has taught us about the limitation of guidelines. And this is a statement that's true today as it was when Bill Gertz first wrote it. Thromboprophylaxis is recommended for groups of patients for whom the benefits of this intervention appear to outweigh the risks. Decisions about prescribing thromboprophylaxis for the individual patient are best made by combining knowledge of the literature, including recommendations provided herein, along with clinical judgment, the latter based on specific knowledge about each patient's risk factors for VTE, the potential of adverse consequences with the thromboprophylaxis, and the availability of various options within one center. Since most thromboprophylaxis studies included patients who are at particularly high risk for DVT or adverse outcomes, their results may not apply to those with previous VTE or with an increased risk of bleeding. Under these circumstances, clinical judgment may appropriately warrant the use of a thromboprophylaxis option that differs from the recommended approach. In other words, a great number of patients encountered in clinical practice have specific individual risk factors that would make them ineligible for the trials used to create the guidelines. I see this all the time. The guidelines are based on average risk patients. They have to be. They can't be skewed one way or the other. But oftentimes in clinical practice, those patients you see are not average risk. They're high risk. So how do you handle that situation? Well, here's some of my suggestions. And that starts with this concept of the high five. Let's take a routine situation, 42-year-old male for elective cholecystectomy with a BMI of 29, no additional risk factors, surgery is uneventful. No prophylaxis except pneumatic compression during the operation is used. The latest ASH guidelines recommend against pharmacologic prophylaxis for laparoscopic cholecystectomy. Patients with other risk factors, such as history of VTE, thrombophilia, or malignancy, may benefit from pharmacologic prophylaxis. Now, there's a whole group of scientists and clinicians in this world that take these guidelines literally and will not deviate from them because they represent what they consider the standard. So only those three risk factors would be interpreted by certain people as indicating that there's an increased risk of thromboprophylaxis and prophylaxis should be used. Now, we'll get to that with this next patient. 76-year-old male with severe sleep apnea, BMI of 41, and insulin-dependent diabetes. He undergoes laparoscopic cholecystectomy. Now, the clinicians decided to give this patient 7 days of low molecular weight heparin prophylaxis, including IPC during the hospitalization. It's based on the latest literature, and he makes an uneventful recovery. Now, that's not covered in the ASH guidelines. Sleep apnea, insulin-dependent diabetes, and morbid obesity and age are recognized risk factors. And if you take a careful look, as long as a risk factor has bona fide data to support its use as a risk factor, it has to be calculated in evaluating the patient. And here, these risk factors make this a very high-risk patient. And the other thing is, why did they use 7 days of prophylaxis? Well, we have 43,000 patients with 160 centers worldwide with hard endpoints. People negate and poo-poo this literature because it's old, but it was based on hard endpoints. Venography, Pulmonary angiography. We don't have those data today. Autopsy adjudicated fatal pulmonary emboli. These are solid data. And yet, why do the guidelines continue to suggest using anticoagulant prophylaxis only until the patient is ambulatory or goes home? That flies in the face of references 4 to 7 right here. Now, Ashline, as I said before, Ashline guidelines only recommend 3 risk factors that merit for prophylaxis if you're going to interpret it literally. So the fact that this patient didn't have these 3 risk factors, that means that according to the guidelines, prophylaxis wouldn't be used. So you can see here, this is complicated. But you have to take all the evidence under consideration. And if you don't know the literature and some important past literature, you're going to be at a disadvantage and or have to repeat it. Excuse me. Here's another situation, a 77-year-old female admitted to ICU. She has diabetes. She has a large hemorrhagic stroke on April 1st. And on April 19th, she gets a big PE, multiple PEs. What do? What treatment do you give her? She just bled. Well, we look to the Riete database, which is real-world information. This is 132 hospitals from around the world where doctors have entered patients who've had a DVT. What are their risk factors? How were they treated? And what were their outcomes? Based on real-world data. And we have 2 really important trials that give us some clue about how to treat this patient. And these trials show you that in patients with no recent major bleeding, they have a 0.6% fatal bleeding rate compared to 4.1 if they had recent major bleeding. And same thing with fatal recurrent PE. 0.5% against 2.4%. So what are you going to do? You're going to give anticoagulants and have this patient bleed to death, or you're going to withhold anticoagulants and even put a filter in and watch them die of recurrent PE? Well, here's the way this is a chart that helps to clarify that. In these studies, recent bleeding was bleeding within 2 weeks of the event. And if a patient had bled less than 2 weeks and was given anticoagulants, that they had a high risk of dying and of having recurrence, but of having fatal bleeding. If that patient didn't have a bleed within 2 weeks of giving him the anticoagulants, then that patient had no greater risk of bleeding than somebody that never bled before. Now, it's a slippery slope, but you can talk to the family and say, based on this data from Riete, since more than 2 weeks have elapsed since the patient got their stroke, the bleed, and the bleed is stable, we're going to try some low molecular weight heparin because otherwise your loved one may die of a fatal pulmonary embolism. And of course, you have to engage the patient's family and you have to all discuss this and come to a conclusion. But you have to make sure that you present the proper facts so the family can make an informed decision. Now let's talk about scores. Well, we like to use the Caprini score because it's a 40-element history and physical that's been worked on by people from all over the world. It's been very successful, not because of me, but because of all the wonderful people that have helped working on this. And we know that the more risk factors a patient has, the higher their chance of a blood clot. We also know that the risk factors vary in their power. Bed rest is a low risk power for producing thrombosis, whereas pancreatic and lung cancer are high risk. So if you combine the number of risk factors and their power, you come up with a score which represents a nonlinear increase in clinical VTE rate with increasing score. Here are the results in general surgery. There's now been over 5 million patients validated in 370 publications to date. People working on this all over the world, showing where it works, showing where it doesn't work, showing where it needs improvement. And my hats are off to all you people from around the world that have helped on this. Now, let us take a look at further into the Caprini score. This is a patient that's 42 years of age with a BMI of 29 and on birth control pills. Patient has 3 risk factors. The Caprini score is 3 because each of them are worth a point. Now, here's another patient who only has 3 risk factors, but is aged over 75, a history of pulmonary embolism, and a past cancer. So, although each patient has 3 risk factors, the combination of number of risk factors and their power result in a more accurate estimate of VTE risk compared to a simple list of risk factors alone. The set point for highest risk also has been a subject of great debate. Initially, when it was Caprini score was first suggested by Chest in 2012. The set point for highest risk was they considered to be 5 and above. But we now know that it's a very complicated situation, and you have to know what your individual population is doing. Hats off to Kiri Lobostov and Thomas Urbanik, who really put together a correlation with the Caprini score and VTE incidence. And they've narrowed it down after looking at 4,562 references to 68 studies that enrolled 4,207,895,000 patients. And look at the results. Green is a low incidence of VTE, and it goes all the way up to dark red, which is over 25%. And you can see a vast difference. Here are scores above 8. Here's the line of 8. And 8 represents as usual cutoff for above 8 is the highest risk, but it varies somewhat. And you can see the risk assessment here of 3% in overall mixed population, and the medical patients 2.2%. With COVID-19, it went up to 28. Cancer 40%. Trauma and orthopedics 47%. So you've got to know your threshold. And the VTE risk for individual patients increases dramatically at a threshold of 7 to 11. I still see papers out where they're looking at Caprini scores of over and under 5 and calling that the highest risk. You need to take a look at this latest data. The other thing is patients love to be involved in their medical care. It's difficult to collect all these risk factors, but if you use a patient-friendly risk form, and you can see my friends and colleagues from around the world have created a number of patient-friendly risks. It's the same form in number of languages. Empower the patients. Now, there's 2 forgotten factors. They're very, very important. Number 1 is obstetrical history. Patients who have recurrent unplanned abortion, stillbirths, premature birth with toxemia, or a growth-restricted infant. Any of these historical events may signal that the patient is carrying an anticardiolipin antibody, which is lupus anticoagulant, antiphospholipid antibody, which is lupus anticoagulant, single anticardiolipin antibody, or beta-2 glycoprotein. If all 3 of these are present, the incidence of venous thrombosis is very high. Now, here's the punchline. These thrombophilia markers in certain women may persist throughout their life, regardless of the fact that they're now many years removed from their obstetrical career. And so these patients, when they get older and need hip replacements, they need cancer surgery or whatever, if you don't ask them about their history of obstetrical complications, you may miss those patients that are harboring a very serious thrombotic event, and that may spell the difference between success and failure or having a serious or fatal blood clot. Remember that. And there's no other risk assessment that takes a look at this. And I want to add that when I was putting my risk assessment schema together, my maternal fetal medicine associate, Dr. Holly Cassells, said, Joe, you better put these complications in because they're important. And yet nobody else has picked up the ball. And this is one of the many areas where women are underserved in our current day life. The other biggie is family history of thrombosis. Now, this can occur in first, second, and third degree relatives. Here's a study that hasn't received much press. In 183,000 patients over 25 years following these people, and you can see how the risk increases depending upon whether it's a first degree relative is the highest, and then it goes down. And even people that live together may have a slightly increased risk, and that may be due to lifestyles. So we're going to come back to that in a minute. But when we take a look at all the other risk scores except one from Britain, nobody else talks about family history. They just talk about thrombophilia markers. And as we know, most patients that get a DVT, if tested with all the markers, will be negative. So that's not the right target. Now, let's talk about the other scores, because there's many roads to Rome. It's not only the Caprini score. The Padua score is very effective and is used around the world in many locations. And with a score of above 4, those people are considered at high risk. But if they don't get prophylaxis, an 11% incidence of VTE compared to when they do, it's 2.2%. So very, very, very good discriminator in medical patients for high and low risk of thrombosis. And this has been used many places throughout the world. You can't always collect all the 30 factors, so you have to be mindful of that. Another score, which is very popular, is the improved score with or without the D-dimer addition. And this score, again, shows a linear increase in an increase in venous thromboembolism, not necessarily linear, depending on the score. And it's been a very powerful model. And it's been also associated, the authors came up with a bleeding score, which also helps to define bleeding risk in the medical patient. This is mostly used in the medical patients. And then finally, they showed clearly in patients, this is an outpatient population, and they were high risk, and they were given rivaroxaban for 35 days, and you could see a 67% risk reduction in the 35-day incidence, which was a composite of symptomatic VTE, VTE-related death, asymptomatic VTE, and symptomatic arterial thrombotic events, MI, and non-hemorrhagic stroke, and cardiovascular death. Very interesting data to show the importance of outpatient prophylaxis. Now let's talk about another risk score. This is a risk score from the United Kingdom, which is a very good risk score. And they talk about family history of thrombosis. And what they did is they tied completing the score and following the recommendations to reimbursement. And when that was done, all sorts of good things happened over a 2-year period. But the punchline is, following this reimbursement recommendation based on reimbursement, 940 deaths were prevented during a 2-year period. So the nudge of tying a risk assessment validated pathway to treatment to be used universally prevented fatal pulmonary emboli. And that's what you need. You need you need to have a way to enforce pathways that have been shown to be evidence-based. Now let's switch gears a little bit here and talk about another scenario, which is, I see so many of these. 42-year-old female patroller suffered a displaced tibial plateau fracture, a BMI of over 35, on oral contraceptives, chronic leg swelling, and ulcerative colitis. She has a surgical repair placed in a leg brace, straight leg brace, and non-weight bearing on the affected leg. If you look at her Caprini score, it's 13. However, when you look at it from the eyes of the average surgical practitioner, this is a young woman who's very athletic, who had a fracture and has been repaired. Doesn't necessarily indicate that patient's a very high-risk patient. She's a young, healthy athlete, so she had a fracture. So what happened to the patient? The patient was discharged the day after surgery, and she's experiencing increased pain and leg swelling over the first 3 days. And they say that's pretty normal for this operation. So they give her some narcotics. And then 1 week after surgery, the patient arrests and dies. Autopsy shows DVT in the legs and extensive pulmonary emboli. And at the autopsy, there are various ages of the clots. You can age clots by looking at their histology, and there are some clots in the legs that are over 3 days old, and other clots in the legs and went to the lungs, which are more recent. And when you take a look, and so then people look at the guidelines and they say, oh, the chest and ASH guidelines don't recommend prophylaxis for lower extremity fractures. But what people miss is, and then they also say that, well, if the patient again has a higher risk, particularly a DVT or cancer, that you should give them prophylaxis. But here's the problem. This lady had a tibial plateau fracture. That's not a lower leg fracture. It's a knee fracture. That's number one. And number two is this discussion about lower leg fractures is in moderate risk patients. This is not a moderate risk patient. She had all these high risk factors, including inflammatory bowel disease, chronic leg swelling, high BMI, birth control pills, straight leg brace. And a straight leg brace can block the popliteal vein and lead to a further decrease in the circulation. So the next time, but the whole point of this study is assuming that you interpreted this patient and what you did to this patient the way these clinicians did. I'm not throwing them under the bus. This is a common scenario. But if you do that, then the next time you encounter a patient like this, aren't you going to maybe give them anticoagulant prophylaxis in order to maybe get a better outcome? Clinical experience and judgment. Clinical experience comes with a lot of scars, and this is a typical example. Now, also remember that as a clinician, you treat patients. You don't treat the guidelines. And here is the most powerful study that shows that although pulmonary emboli are the leading preventable cause of death in postoperative patients, that the administration of heparin or low molecular weight heparin resulted in an autopsy adjudicated rate of fatal PE of 0.1%. And sure, there are patients that get clots, but they don't die and they don't bleed to death. And what's furthermore, what is the punchline here, and not to be forgotten, this is 23,000 surgical patients with the ultimate endpoint of an autopsy-adjudicated PE. All patients received at least 7 days of anticoagulants prophylaxis, and some longer, up to 20 days, depending on their risk. Now, here's a chart that shows that VT events are trending higher. Why? Despite all this data, despite everything I've shown you? I don't get it. Well, I think it comes back to what the British showed us. And that is there's a disconnect, just like between the rider and the motorcycle, there's a disconnect between evidence-based execution and VTE prevention. And reducing VTE deaths requires mandatory implementation of appropriate care pathways. When that was done in the United Kingdom, they saved 940 lives. And in the United States, we have an excellent example of this in studies from Boston University. They've published 16 papers since 2014 on this subject. And they had a mandatory program where patients had to fill out the Caprini score, and depending on the Caprini score, give them prophylaxis. And during hospitalization, if the score was up to 4, you could do whatever you wanted. But if the score was 5 to 8, they had to receive 7 to 10 days of low molecular weight heparin. Didn't make any difference if they went home or not. And the same thing if they had a score of over 9, 30 days of low molecular weight heparin. And there was a high buy-in of this. But here's what's astonishing. Yes, there were people in the beginning, clinicians, that were skeptical of this and so forth. But as they saw these results in other patients improve, they wanted to be part of the success of the program. So one of the nudges that helped this to be successful, and look, they've kept their rate down for over a decade. So how did they do that? First of all, by example. They didn't yell and scream at anybody that didn't fill it out. If you didn't fill out the form and follow it, you had to give a reason. But eventually those people came around. Now, the other thing is that they also made an arrangement with the drug companies and with CMS and insurance providers to give anticoagulation to every patient, regardless of their ability to pay. And this wasn't any high rent district only hospital. Boston University is the #1 safety net hospital in the Boston area, responsible for, in part, of course, for the care of the indigents. So, but this is an excellent example that what you can do with mandatory implementation. So, in conclusion, the risk assessment procedure must be followed in order to prevent venous thrombosis, including fatal PE events. That risk assessment procedure includes all the elements, not just the score. Family history of thrombosis and obstetrical complications are key. And I don't care what risk assessment you use, because there are many roads to Rome. But please track family history of thrombosis and obstetrical complications. They are really key, and they may spell the difference between a successful outcome and a serious or fatal one. Remember, the score is a dynamic instrument, and it must be updated during hospitalization, regardless of which score you use. Patients develop problems after they're admitted. They have to have recurrent surgery. They develop infections. They need central lines. They come up with cancer that wasn't suspected. You've got to update your scores, and then at discharge, do a final score and see if they qualify for post-discharge prophylaxis. Extended prophylaxis following discharge is very important for patients with high-risk scores in any of the models. Mandated use of evidence-based algorithms employing Nudge techniques to assure compliance are suggested to lower the incidence of fatal pulmonary emboli. Peer review, financial incentives, practice audits, or leading by example. Finally, depending upon the healthcare system, the country, the culture, and the ability to collect data, these processes must vary and has to be tailored to the individual situation. Finally, remember about the Caprini High Five as a guideline, and don't just think of risk assessment as picking a particular tool. Guidelines are only the beginning of the risk assessment process. That's the other thing. Many patients in the guidelines are average risk. Your patient may be very high risk. So I'd like to thank you all very much for your attention, and I'd like to ask you to visit my social media sites for more information, and have a wonderful day and a very successful meeting.